Dr. Castera, what are the main advances in non-invasive assessment of hepatic fibrosis in the last decade?
So, non-invasive assessment of liver fibrosis has been one of the major advances in hepatology that really revolutionized the management of patients with liver disease worldwide. Actually, it all started in France about 15 years ago with two different approaches, but complementary. The first approach was based on the dosage of serum biomarker, and the second approach was based on the measurement of liver stiffness using elastography technique, for which FibroScan has been the pioneer. So, one of the major advantages of transient elastography, it's a point-of-care technique that can be performed in the outpatient clinic or at bedside with immediate results. This is the most validated technique worldwide, and now it's used in every liver clinic over the world, including in the US, where it's been approved by the FDA in 2013, if I recall. And to stratify patients, when you see patients with liver disease, this is what you're using, transient elastography. If you're above 10 kilopascal on a scale that goes from 2 to 75, you're likely to have compensated chronic advanced liver disease, pre-cirrhotic, and if you're above 15, your likelihood is even higher. So above 15, the probability of having what was called cirrhosis, compensated cirrhosis, is close to 90%. However, you need to be aware that the risk of false positive is higher than the risk of false negative. In other words, these techniques are better at ruling out than ruling in cirrhosis. Why? Because inflammation, for instance, in hepatitis B, may be associated with false positive cases. Also, the patient should be fasting, otherwise there's risk of false positive. And if you have acute inflammation or acute hepatitis, or like you see in hepatitis B, when their transaminase flare above 10 times the upper limit of normal, there's a risk of false positive. Last but not least, operator experience is also important and has to be taken into account.
Sir, what are the factors associated with the accuracy of non-invasive assessment of hepatic fibrosis?
So, the major limitation of transient elastography, as I mentioned before, apart from the other factor, is obesity. And as you know, now worldwide, the leading cause of liver disease is becoming NAFLD, non-alcoholic fatty liver disease. It's more predominant in Western countries than in Eastern countries and in Asia, but still the prevalence is increasing fast. And when transient elastography started with a regular probe, this was an issue for applicability, and applicability was around 80%. Now, this has been solved, and with the new probe, the so-called EASL probe, the applicability is very high, is around 97%, so 3% of failure rate, in other words. And again, this is a very interesting tool to stratify your patients in the clinic. Also, what is important in patients with cirrhosis, compensated cirrhosis, you might be able to predict decompensation according to the value of liver stiffness. And for instance, I mentioned the value range from 2 to 75 kilopascal. If you're below 20 kilopascal, most patients will be compensated. And let's say above 50 kilopascal, so from 50 to 75 kilopascal, most patients will have already experienced complication. In between 20 and 50, this is a gray zone. So this is a very useful tool in your clinical practice to stratify the risk of your patients in terms of complication, occurrence of complications, liver-related, but also mortality.
What is your opinion now about the usefulness of liver biopsy for the assessment of liver fibrosis?
Of course, the number of liver biopsy has been really reduced since the introduction of this non-invasive method, but there's still, I think, a place for liver biopsy. So, for instance, if you're using several non-invasive tests, let's say a serum marker and transient elastography, when there's discordance, you might use liver biopsy to resolve the discordance issue. Also, in NAFLD, if you need to make a diagnosis of NASH, so the active component of the disease, non-alcoholic steatohepatitis with inflammation. This cannot be done with this method. And then you might need a liver biopsy. And for instance, currently with all the ongoing therapeutical trial in NAFLD, liver biopsy is still mandatory. First, to know whether there is NASH or not. And second, to assess the disease severity in terms of fibrosis stage. So there's still a place for liver biopsy in these patients.
Very good. Doctor, thank you so much.